Thank you very much, Silke, and thank you very much for pronouncing my last name correctly. I would also like to thank the Guideline Board Committee for the very honoring invitation to give this talk, and I would also like to thank all members of the Stroke and Women Guideline Group, and in particular Christine Kremer and Valeria Kazel, who spared no efforts and time during the long course for the completion of these guidelines. Now, let's start with this Gustav Klimt painting titled Hope 2, which depicts a pregnant woman, most probably a queen, dressed in this magnificent gown and surrounded by her ladies of the court who keep meditating or perhaps praying in an attempt to avert any threat that may endanger the mother or the new life. We even see a skull on the woman's abdomen. This painting epitomizes that women are magnificent creatures with extrinsic and intrinsic beauty who possess the gift of giving life, but who are exposed to risks inherent to their gender. And now, after this brief philosophical artistic intro, let's move to the body of my talk. Although the majority of stroke burden in women can be attributed to traditional vascular risk factors that occur in both men and women, there are several stroke risk factors that are specific to women. In particular, these gender-specific risk factors are endogenous and exogenous sex hormones and pregnancy with a puerperium. We will deal in detail with these risk factors unique to women. However, please notice that even traditional risk factors may be potentiated in women, either because the strength of association is higher in women or because the frequency and therefore the population attributable risk is higher in women. This potentiation may apply to hypertension, AFib, diabetes mellitus, dyslipidemia, depression, and migraine. Let me remind you that female sex is part of the CHA2DS2-VASc risk assessment score for AFib, but this is the subject of a different talk. We will now start with pregnancy. Pregnancy is associated with myriads of physiological changes in the woman's body, and in particular with many changes affecting the circulation and the hemodynamic status of the mother. Speaking of cerebral arteries, these changes are structural, affecting arterial wall thickness and composition, but they're also functional, affecting contractility and endothelial reactivity. In this graph, we can see the major hemodynamic changes during pregnancy with a significant increase of the cardiac output, the considerable decrease of the systemic vascular resistance, and the restoration of these variables to baseline during the postpartum period. We should also keep in mind that during pregnancy, the equilibrium between coagulation and inhibition of coagulation fibrinolysis is shifted towards the activation of the coagulation cascade. So to place it correctly, pregnancy is a physiologic prothrombotic state or a state of accelerated but compensated intravascular coagulation. The incidence of stroke during pregnancy at the puerperium varies across different series from 20 to 90 cases per 100,000 pregnancies. If we stratify stroke incidence by type of stroke and by time point, we see that the vast majority of pregnancy-associated strokes are peripartum strokes occurring within 1 to 2 days before and after delivery. And this is true for all types of stroke, for brain infarction, for ICH, and for subarachnoid hemorrhage. You see that practically all strokes occur the incidence of stroke during pregnancy is very low during the whole pregnancy, only to rise steeply just before delivery and then to decline again 24 hours postpartum up. It seems that stroke rate during pregnancy parallels the risk of accident during a flight, where most of the accidents occur during takeoff and landing. Furthermore, apart from the risk of stroke during pregnancy and the postpartum period, an expanding body of research has shown that complications of pregnancy like preeclampsia, gestational diabetes, and pregnancy-induced hypertension are associated with higher risk for future cardiovascular disease and stroke beyond the childbearing years than among women without these disorders. For example, across several series, women with a history of preeclampsia have a 2 to 20-fold increase in risk for development of chronic hypertension. And as we can see from this recent publication from a cohort study in Finland, at least 50% of women who presented gestational diabetes mellitus will develop diabetes mellitus in later life. Both hypertension and diabetes mellitus are major stroke risk factors, as we know. Two meta-analyses, one from the UK and one from Canada, from the McMaster, showed that women with a history of preeclampsia have almost twice the risk of stroke compared with women with uncomplicated pregnancies. Despite these accepted associations, it may be decades before women with a history of preeclampsia or gestational diabetes mellitus have formal cardiovascular risk factor screening and treatment, thereby accumulating atherosclerotic burden in the meantime. Now, we will leave pregnancy and we will examine the role of endogenous sex hormones as gender-specific stroke risk factor in women. We know that estrogen levels fluctuate dramatically in women during the menstrual cycle and then drop dramatically in the menopausal transition and in postmenopause. In data from the Copenhagen City study, neither high nor low estradiol levels were associated with increased risk of ischemic stroke in premenopausal and in postmenopausal women. Only premenopausal women, and only those in the lowest 10th percentile of estradiol, had a twofold increased risk of ischemic stroke. You can see this on the left-hand side over the bottom panel. But this association was based on small case numbers. On the other hand, testosterone levels are more stable than estrogen levels across the lifespan in women, and the investigators found no association between high or low testosterone levels and risk of stroke in premenopausal and in postmenopausal women. Low dehydroepiandrosterone levels have been associated with increased risk of ischemic stroke, with women in the lowest quartile having a risk for ischemic stroke increased by at least 40 to 50% after adjustment for other risk factors. And there are also data suggesting that dehydroepiandrosterone is inversely related with stroke severity and mortality. Concerning age at Minarchy and stroke risk, the Million Women study from the UK showed a U-shaped relationship between age at menarche and cerebrovascular disease. Women who experienced menarche at age less than 10 years were at higher risk of developing stroke in later life, as you can see here, compared with those age at menarche at 13 years. And the same way, women who had menarche beyond the age of 17 years were also at higher risk of developing stroke. We discussed about the age at menarche. What about the age at menopause? In a recent meta-analysis, investigators reported that early age at natural menopause, that is menopause onset before 45 years, was associated with a 50% higher risk of cardiovascular disease. However, this was not as evident for cerebrovascular disease. This was marginally non-significant, as you can see on the right-hand side. And a similar trend may also apply to surgical menopause. But perhaps the clue is not just in the age at menarche and menopause, but in the total duration of a woman's reproductive lifespan. In the prospective cohort of Nurses' Health Study, a shorter duration of reproductive lifespan, that is less than 30 years, was associated with a higher risk of stroke, as well as a higher risk for cardiovascular disease. However, these effects were likely driven by earlier age at menopause, either naturally or surgically. Now, let's move to a major issue, and that's the influence of exogenous sex hormones on stroke risk. COCs, that is combined oral contraceptives, comprise both estrogen and progestogen. They're thrombogenic and historically have been associated with increased risk of cardiovascular disease. According to this relatively recent meta-analysis by the Cochrane group, COC users were at increased risk of myocardial infarction or ischemic stroke compared with non-users. The relative risk was 1.6, and these relative risks were similar for myocardial infarction and ischemic stroke. Oral estrogens have a dose-response association with risk, and doses have declined since their first introduction in the 60s. Most COCs now contain less than 50 micrograms, and some contain as low as 15 micrograms of estrogen. We can see from the same Cochrane meta-analysis that the risk of myocardial infarction or ischemic stroke increased with increasing doses of estrogen, from a relative risk of 1.6 for preparations containing 20 micrograms of estrogen to a relative risk of 2 for preparations containing 30 to 49 micrograms, and to a relative risk of 2.4 for preparations containing more than 50 micrograms of estrogen. On the other hand, progestogen-only hormonal contraceptives have not been associated with increased risk of ischemic stroke, although data are limited. This forest plot comes from meta-analysis up to 2009, and this table over here is from the more recent Danish cohort by Lidergaard and colleagues confirming these findings. By contrast, non-oral methods of delivering combined hormonal contraceptives, including the vaginal ring and contraceptive patches, seem to have the same risk as oral contraceptives. The administration of exogenous sex hormones in the context of other risk factors may create an explosive combination. The risk of stroke in patients with migraine with aura is increased twofold. Women with migraine who also use CFCs have a 7-fold increased risk of ischemic stroke, whereas women with migraine with aura, COC use, and who are active smokers have a dramatically elevated 10-fold risk for stroke. And this is a beautiful example of the interplay between conventional risk factors and gender-specific risk factors in women. Now, we'll move from birth control pills to hormone replacement therapy in postmenopausal women. In the Women's Health Initiative, women randomized to combined estrogen plus progestin for primary prevention had a hazard ratio of 1.3 for total stroke and of 1.44 for ischemic stroke. In the Women's Health Initiative trial of estrogen alone, women randomized to active therapy had a hazard ratio of 1.4 for total stroke and of 1.5 for ischemic stroke. The figures here show the cumulative hazards of ischemic stroke for women in the estrogen alone and estrogen plus progestin trials. In the E plus P in the combined trial, the actively treated group began to show an increased risk of stroke by year 2 of follow-up, whereas in the estrogen alone trial, the increased risk in the actively treated group did not appear until after 4 years of follow-up. Although some data suggest an association between timing of hormone therapy and coronary heart disease, time since menopause is not associated with differences in stroke incidence in either observational studies or in clinical trials. Analysis of data from the 2 trials of Women's Health Initiative showed that timing of initiation of HRT since menopause impacts on coronary heart disease risk, with women starting HRT more than 20 years after menopause having the highest risk. On the contrary, the risk for stroke was consistently high regardless of time since menopause. And also data from the Nurses' Health Study suggest that, as in the case of birth control pills, there is a dose-response relationship between the dose of oral conjugated estrogen and stroke, with no increased risk for a dose of 0.3 milligrams, 1.54 at 0.625, and 1.6 at 1.25 milligrams of estrogen. HRT does not seem to work for secondary vascular prevention either. The West study, the Women's Estrogen for Stroke trial, in women with recent mild ischemic stroke or transient ischemic attack found no significant effect of treatment with oral estrogen on risk of stroke recurrence, even there was a trend towards harm. The primary outcome was death and non-fatal stroke, and there was no difference between the two arms. Fatal strokes were, interestingly, numerically but not statistically higher, and this was mainly driven by ischemic strokes. Now, concerning the route of administration, limited data are available for transdermal estrogens, which have been associated with lower risk of venous thromboembolism. In a population-based study from the UK, current use of transdermal hormone therapy was not associated with an increased risk of stroke. However, when the dose was examined, low-dose transdermal estrogen, less than 50 micrograms, was not associated with risk, while high-dose transdermal estrogen was associated with increased stroke risk. And in this study, there was also a dose-dependent stroke risk increase for the oral route, as we have previously mentioned. So, bottom line, specific considerations that include endogenous hormone levels, exogenous hormone therapy, pregnancy, and the peripartum period change the risk of stroke for women, as well as the optimal stroke prevention strategies. We need further research to determine whether risk prediction models should include risk factors specific to women, including hormonal and reproductive exposures. Well, I started my talk with art, and I will finish it with art as well. This quote belongs to William Congreve, an English writer of the late 17th century. Women are like tricks by sleight of hand, which to admire, we should not understand. I cannot agree more with Mr. Congreve. However, by adapting the quote to our context, I will say that understanding stroke risk factors unique to women and their interaction with traditional risk factors is a research priority and a prerequisite for understanding stroke in women. Thank you very much.